All right, welcome back to PT Meal Podcast, a buffet of play therapies, movement, exercises, activities, and leisure, all packed in a hearty conversation of physical therapy profession and practice with a Filipino flavor. I am Johan de La Paz, your host, as always. Thank you for joining us. Sorry. So for this episode, uh, we are joined by our former guest, Eleazar Tayag, to talk about hospice care primarily and some parts like probably of palliative care as well. So well, before anything else, let me welcome my guest for today, Eleazar Tayag. He's a board certified clinical specialist in both orthopedic and geriatric physical therapy. He owns a home health agency, a hospice agency, and a um, home health rehab company. So, Ellie, welcome back to the show.
Well, my pleasure, actually. Thank you very much for having me again. I think it's
uh,
been 2 years, right?
yeah, it's been 2 years.
More
He's
than 2 years.
Yeah, Ellie was one of the first guests that I had in the podcast. And if he talked about home health, what is home health here in the US, and if you want to check that out, it's I think episode 12 in the podcast. So so long ago, 2020. So I'm glad to have Ellie back here to talk about hospice care. So we were talking about earlier like why hospice care. Um, because when I came over to the US, I wasn't really no, I didn't know that physical therapists have any role in hospice care. So when I was in in the Philippines, the only time that I heard about hospice was when we're doing outreach programs, right? Like in schools, and we go to hospice to entertain the patients there, give them like food and talk to them, and that was all that I know about hospice. But hospice care here in the US entails a different type of care, and that's what we're going to talk about today. So, before anything else, uh, Ellie, could you introduce yourself to us for those who don't know you yet? A little, description or a little a description of what you do.
Yes, my name is Eleazar Tayag, like what Johan said. I'm a double certified PT specialist in both orthopedic and geriatric physical therapy. So I am the administrator of Imperial Home Health, which is based in Victorville, California, and the clinical operations manager for Caring Shield Hospice in Riverside, California. So I'm currently one of the faculty of the advanced competency in home health by the American Physical Therapy Association. So home health section. At the same time, I'm a board of trustee of the nonprofit organization Future Foundation, which advocates for the Filipino physical therapy profession. At the same time, the multicultural physical therapy group of the American Physical Therapy Association.
All right. See, so who better to ask about, home health and hospice than Ellie here. So, let's get right to it. So, first question is, what is hospice care? And later on, like, what is palliative care?
Yes, hospice care is technically the end of life medical care. So that's basically it, because we have to understand that there is a usual stigma with death, and especially in the Philippines, for example, compared to the United States, which we're in hospice, or the end of life care is more accepted more than in the Philippines. So let's do a little bit of history of hospice care. So when you say hospice care, a hospice, it
Mm,
actually came from a Latin word hospitum, which means hospitality or guest house. So basically, the origin of the word, it came from like religious monasteries, I believe in France, where they provide home and shelter and food for the travelers. So hospice was founded in Lyon, in France, actually,
Mm.
by Jean Garnier. So from Jean Garnier, it's more of like caring for dying patients or clients. There's really no structure in the care. But
Mhm.
in 1967 in London, there is this very famous hospice trailblazer. Her name is Dame Cicely Saunders. She founded the modern hospice movement. This is where hospice care in America is patterned from, where there's medical care for patients, usually in their home at the end of life. So we have to remember that the hospice philosophy is different from, like, for example, home health. The philosophy of hospice is comfort care versus cure.
Mhm.
So we have to remember that, a death should be an accepted phase of life.
Mm.
Death should be death is inevitable. I mean, inevitable in eventuality of life. It's just some people die sooner than others. They die later. In the Filipino, they say una-unahan lang. It's the same. It's the
Right.
same thing. So in hospice, you embrace the last 6 months of your life. So you pretty much uh, embrace death, make peace with death.
Mhm.
So, like what I said a while ago, hospice is technically medical care at the end of life, especially for patients with terminal illnesses like, let's assume, advanced heart disease, cancer, stroke, lung disease, liver disease, kidney disease, HIV, ALS or Lou Gehrig's, multiple sclerosis, and other neurologic diseases. We also have to understand that hospice is a service; it's not a place. A lot of people, have that misconception that hospice is a place to die.
Right.
Actually, you can have hospice care anywhere you feel comfortable. Any home that you consider. So it
Mhm.
can be at your private residence, it can be at the hospital, it can be in an assisted living facility or skilled nursing facility, and so on and so forth. So what hospice goal is to make the most of the time that remains. So you die with honor and dignity. At the same time, you provide support for the hospice patient and also the family members who are involved in the care. So yeah, your wishes are honored. Um, the focus a lot on comfort care, like manage pain, symptom symptom relief versus cure.
Mhm.
So hospice is believed, you know, to improve the quality of life in the last 6 months. But at the same time, a study found that it actually increases the quantity of life at the same time. So it improves the quality at the same time increases the quantity. They're saying that on the average, hospice patients actually live 29 days longer
Oh, really?
than those ones that never received hospice care.
Mm.
So this was a study way back in 2007 by O'Connor and colleagues.
Mhm.
So in hospice, the focus is a lot on comfort care, at the
Mhm.
same time, support, emotional, social, spiritual support. So, I can give you examples of patients who are appropriate for hospice. For example, somebody who has a terminal cancer, pancreatic cancer, for example. My dad died of pancreatic cancer. So, I've faced, these types of situations where you have to make very difficult
Decisions.
discussions
Mm.
and decisions. Yeah. And also my my mom in 2014 was, in coma for a few days. So we had to make those healthcare decisions. It was really, really difficult, especially if there's really no advanced care directive. Philippines is not really a place where it's very common to have advanced care directive unless you're in the wealthy side where you have to distribute the wealth and so on and so forth. So it can also be patients, those cancer patients that have given up on chemotherapy or radiation therapy. They're not seeking any treatment any longer. I mean, in a way, they don't want to seek further treatment because the doctor probably said the illness is terminal, or looking into pros and cons of going through chemo. I mean, managing all the side effects of chemo or radiation probably is not worth it. So some of the patients will say, I don't want to go to the hospital. I don't want to have chemo. I don't want to have radiation. So those are the patients that are appropriate for hospice. I mean, hospice care and home health care are pretty much in a way the same in a lot of ways. It's just the philosophy for hospice, like what I said, is purely comfort care versus home health, which is curative in nature. But the hospice team or the home health team are almost different. I mean, almost the same. There's a little bit of tweak. For example, the hospice team is comprised of a hospice doctor, a registered nurse, a social worker, a hospice aide, hospice aide or the home health aide in home health side, in addition to chaplain. So, chaplain, which can partner with a patient's own clergy, like a priest, a pastor, or whoever. Additional part of the core hospice team would be a community volunteer for companionship, and lastly, bereavement specialists. So these are people that are that specialize on grief and loss support. So this is based on the like what CMS describes as the hospice team, but there are complementary or other disciplines like physical therapist or occupational therapist or speech therapist or massage therapist that can be part of the team. But the core team are those: the doctor, the RN, the social worker, the hospice aide, the chaplain, the bereavement specialist, and the volunteer. Gotcha. But we play a big role, actually.
Yeah. So basically, hospice care is for comfort, end of life, for the last 6 months. You mentioned last 6 months, and it's a service. It's not exactly a place. You can do, can have hospice care wherever the patient feels comfortable. And how is hospice care different from palliative care? We also hear palliative care in other settings. Is it the same, or how similar or how different are these two?
Okay, so before I discuss that, let's talk a little bit more about the comparison between home health and hospice before we, discuss hospice with
palliative care.
Yeah. So, I mean, there's a lot of similarities for hospice and home health. I mean, normally, of course, it's medical care provided at the patient's home. So they remain at the patient's home. So they provide both physical and psychosocial care. So it also, aside from medical care, both will provide even personal care, like a home health aid care, a hospice aid care. And there is unlimited recertification according to Medicare, so long as there is a need. So
which one is this? Home health or hospice?
Actually,
Or
both.
Both. Okay.
Yeah, so long as the criteria are what's this
met.
Yes, the criteria are met. It's unlimited. So that's one thing that a lot of people don't know, right? So they both have an individualized plan of care. For hospice, it's 6 months or less. The care like terminal illness. There's no homebound requirement for hospice. So
Oh.
even patients can go out, it's fine.
Mhm.
They're not bound by the homebound requirement, and the visits are up to 24 hours a day
Oh, wow.
when medically necessary, compared
Uh-huh.
to home health, which is also an intermittent. However, there is the homebound status requirement. At the same time, visits can be limited to just up to 8 hours a day total, supposedly. These are based on the conditions of participation in the home health and hospice benefits manual.
Uh-huh.
So those are the similarities and differences between home health and hospice. How about hospice versus palliative care? So we have to understand they are sometimes interchangeable, but there is a difference. So
Mhm.
let's tackle first with how are they similar. So they're both comfort care. So
Mhm.
both medical and personal care, like what I said a while ago. But the focus is symptom relief.
Uh-huh.
Same, so symptom relief, comfort care. So they also address both physical and psychosocial aspects for both patients and family members. The main difference is for hospice, it's at the last 6 months. For palliative care is at the discretion of the physician. It can be at any stage of the illness.
Mhm.
So the doctor can order it anytime, so long as the illness is serious.
Mhm.
Okay, it's a terminal illness as well. For hospice care, obviously, it's a terminal illness. It's an advanced stage of the illness. So the intent of hospice, like what I said, is not curative.
Mhm.
Okay, so there is only comfort care. For palliative care, it's also comfort care, but it can be with the intent to cure or not cure.
Mhm.
So obviously, whatever they do in the hospital, where they manage the symptoms, at the same time manage the pain, but also providing providing comfort care, and there's an intention to cure, is palliative in nature.
Okay.
So that's basically the difference between palliative and hospice care.
Mhm. Right. So,
I mean, sometimes what happens is there are patients that are not ready for
uh-huh.
hospice care. They might be in the terminal stage, but we can put them under palliative care because they still have an intention to actually get cured.
Mhm.
One classic example is, like, for example, a patient with end stage renal disease,
Right.
who are undergoing dialysis, for example. These patients undergo dialysis, and there's still an intent to try to cure.
Right.
But if a patient, for example, refuses to go on dialysis, they're tired of the post dialysis issues. For example, they get extremely tired and all that, and they don't want to be on dialysis, they can be under hospice care.
Mhm. And how does the doctors determine if the patient's only going to be or only gonna live for 6 months or less? Is it based on their, all all of their health and stuff?
Well, I believe the doctors you usually have their own criteria, especially
Mhm.
if you, for example, a cancer patient on
Mhm.
stage 4. Obviously, the normal course of cancer, the patient
Mhm.
will pass, especially if
Mhm.
it's a malignant type of cancer. So,
All right.
I mean, in the end, it's usually the doctor that it is the doctor that certifies the CTI, what they call certification for terminal illness. In
Mhm.
hospice, by the way, there has to be two doctors that will have to certify terminal illness.
Mm-hmm.
So the first one can be, whoever is normally the primary doctor in corroboration with the hospice doctor. So
Mm-hmm.
the hospice doctor is the one that does the certification for terminal illness. But you also have to understand that patients can elect the hospice doctor to be also their primary doctor. So if
Mm-hmm.
that's the case, then there's only one MD that needs to sign the certificate for terminal illness.
Mm-hmm. I had a patient back then that was um when I was in home health. The nurse was talking to that patient and opening up the option of hospice. Can patients refuse uh hospice services and continue with, you know, home health services if they wanted to, even if, the doctor has already said that, okay, you might have less than 6 months to live.
I mean, in any type of medical care, a
Mm-hmm.
patient can refuse
Uh-huh.
any type of care. So in
Mm-hmm.
hospice, there's what you call a hospice election. So the
Mm-hmm.
patient should agree, or
Uh-huh.
if the patient, is not mentally competent, there is a healthcare proxy or a
Mm-hmm.
durable healthcare power of attorney or something like that.
Right.
And then the POA or the healthcare proxy will be the one who will decide. But
Mm-hmm.
otherwise, they always have the choice.
Mm-hmm.
So if they refuse, that's why I was telling you a while ago, there are patients that are really appropriate for hospice, but they will never be ready for hospice. We
That's
have,
true.
we have quite a few patients
Mm-hmm.
in the home health side that we've been trying to get them on hospice because they are more appropriate for hospice. So they're really
Mm-hmm.
comfort care, management of symptoms. But some of these family members are not ready.
Right.
So, and it's very, very common for example, in the Hispanic population or the Asian population to let go and not to let go.
Mm-hmm.
Because I think culturally, letting go is giving up in their
Yeah.
culture. But it is an election, so you choose
Mm-hmm.
not to if you don't want to.
Right. And even like for us physical therapists, we coming into physical therapy, I didn't know that I would have to deal with like death and grief and something like that. So I wasn't aware that there would be a time in my life in my career that I would have to deal with that. Speaking of physical therapy, with hospice service, what is the role of physical therapists? You mentioned earlier that we have a vital role in this care as well. So um my experience was that like I when I was in home health, we had like a contract with a hospice agency, and I wasn't sure that what if that is hospice, what would I do there? So what I just did was assess for um DME needs, like how to make the patient comfortable in their home. So if they needed like um a wheelchair or a walker or whatever, or um bedside commode. So those are the things that I had experienced. I think that just was one time. But in in how about you? So what is the role of physical therapists in hospice care, since you're the one that has like a hospice um agency?
Actually, the physical therapists are a very valuable
Mm-hmm.
part of the team.
Mm-hmm.
If hospice agencies would recognize the value of what we do.
Okay.
So, and especially when it comes to symptom control or comfort control. So when it comes to symptom control or comfort control, like when it comes to management of pain, there's a lot of non-pharmacologic ways that physical therapists can do, like um, let's myofascial release, soft tissue
Mm-hmm.
massage. It can also be modalities. I know, in the PT world, modalities are not really the thing now, but for hospice patients that is going through a lot of let's assume nerve pain or cancer pain and all that. Let's assume a TENS unit can actually provide some type of pain relief. And also we can, like what you said, when it comes to durable medical equipment, or let's say consultation for a brace, or things like that, we can also be very, very valuable for that. Just imagine a patient with post-stroke, for example. Maybe a splint or a brace can help, especially for a flaccid, painful arm, for example. Positioning to prevent pressure sores, lessening pain, preventing contractures, helping the patient breathe a little better, or something like that. We can be very, very valuable on that aspect. As simple as energy conservation, setting up the room, setting up the home. There are patients that need to walk, right, to at least maintain their function. If they get extremely short of breath, for example, there is a metastasis in the lungs. So minimal exertion causes shortness of breath. We can set up the home where there can be a chair every 10 feet or something like that until they get to their kitchen, and so on and so forth. Energy conservation technique is also very important, and also gait training, transfer, safety instructions, teaching the caregiver how to properly position patients, teaching caregivers how to do the home exercise for help the patients do home exercise program. Edema management, for example, is a breast cancer patient where the arm is very, very swollen, and it's causing a lot of pain. Edema management can also be part of it. So equipment recommendations as well, like what we were talking about, modification of the placement of the bed, the wheelchair during transfers, the shower chair, and so on and so forth. These are the things that a PT can actually help the patients and the families with. So we have that direct patient care, at the same time the educator trainer role, especially when we teach the patients and the family members. So the thing there is, sometimes we forget that there are certain patients that their mobility, or the ability to move, especially those ones that have always been very independent, creates that sense of self. So if they're just on their deathbed, being able to get out of the bed, walk, do certain things for themselves, restores that sense of self for a lot of patients. And that is I would say some kind of comfort care, if you ask me.
Right.
So also a lot of caregiver education, you can help them reduce their anxiety about taking care of their family members. And lastly, when it comes to addressing shortness of breath, postural drainage. Remember chest PT before, during our time, which is not a very common thing that's done
that we do here
anymore here in the United States, which used to be a part of what we do, but not any longer since the respiratory therapists are here. But positioning, airway clearance, postural drainage, secretion mobilization, the percussion, the shaking, the vibration, all that cupping and all that, it can help with symptom relief, especially with shortness of breath. Chest mobility exercise, for example, the posture is getting worse, so they're using a lot of the accessory muscles. We can help them with that, increase the mobility of the chest, the thoracic cavity, and so on. And so these are the things that a PT can be and experts on. I'm sure you would say yes on those
Right.
those. Yeah, right.
Yeah, actually, when you're talking about that, I mean, I didn't realize that we can do that much with patients in home hospice care. Yeah, because as I've said, my own experience was I thought that I could just like provide the DME equipments. That's the only instruction that I had back then. But you talking about those other treatment that we can offer the patients in their last remaining months or time with us. And I like what you said, like giving the patient or empowering the patient, actually like giving them the sense of dignity of being able to walk around by themselves is, as you said, comfort care as well. And also I would agree that since this is new to and maybe hard for the caregivers as well, education on their part and their role in that care would also be essential. So that's really eye-opening. I didn't know that we can do a lot in hospice care. uh
The thing there is a lot of hospice agencies don't actually see the value in us. I think
mhm,
they feel like physical therapist is additional financial burden for the hospice agency, but ultimately they have to understand the whole purpose of hospice is to provide comfort and relief, and we will be a very important complementary therapy or discipline in the hospice care.
yeah, especially when you say the non-pharmacologic approach to pain. So yeah, we can be one of the good consultants for that. Mm.
Correct.
So for dealing with hospice services, are there any considerations or special approaches in dealing with patients under hospice service, or do you just see that type of patient as any other patient in your caseload, that you identify a problem and the solution, provide a solution for that?
Yeah, I mean it's basically the same,
Hmm.
our approach in treatment where, if you find a problem, you create solutions for it. But when it comes to hospice, the thing is there has to be a buy-in with the patient. At the same time, you as a care professional, there has to be the buy-in into the philosophy of hospice,
Right.
because a lot of times we fall into the trap that we want these patients to get better, but
Right. True.
basically in hospice care, that's not the purpose of
Hmm.
hospice care. The purpose of hospice care is to provide comfort and manage the symptoms. Basically, that's it. So, when it comes to like creating plans of care and all that, you should not be adding goals that this patient will walk from this to this, be independent in this, and so on and so forth, because that's not how how it works. So I
Hmm.
mean, if you change the way you think when it comes to hospice, I mean, especially for a lot of physical therapists who are afraid of even seeing hospice patients, I mean, you will realize how valuable we are as a profession in the hospice
Hmm.
hospice care.
And talking about goals for a patient, we and hospice is provided or paid for by Medicare, right?
Yes,
Yeah,
actually, all insurances
oral
pay
insurances.
for hospice care.
Uh-huh.
I mean, Medicare pays 100%. There's no copay.
Uh-huh.
Private insurances, any VA or like TRICARE, TriWest.
Hmm.
Even if it's a Medicare HMO, for example, once they enroll to hospice care, they're automatically back to straight Medicare.
Okay.
So compared to like home health care, where if the patient is enrolled with a Medicare HMO, the HMO is the one that approves the home health care and will be the one at risk. But for Medicare, it's a different. I mean, for Medicare HMOs, it's a different story. If they have, for example, Humana Medicare or United Healthcare Medicare, once they enroll with hospice, it's actually Medicare that pays for the whole hospice care.
Oh, okay. So,
And just to give you an idea for those ones that I know a few physical therapists that actually own home health and hospice agencies close to our area. I have like 3 or 4 PTs that I know. When it comes to the business side of hospice, it's always it's also a very I would say cutthroat business. It's even than worse than home health, to say the least. Is because hospice care actually is always at the top of the totem pole when it comes to the payment. So the thing there is, if a patient is under hospice care, the assumption is this patient will be given medical care at home. Okay, they should not be going to the hospital to receive medical care in the hospital. Things like that. So if a patient is enrolled in hospice and there's a home health agency that is seeing the patient as well, they don't know that there is a hospice agency that's seeing this patient, the home health agency will not be paid.
Right.
If a hospital treats a hospice patient, they don't bill Medicare, they bill the hospice agency, unless the patient revokes the hospice election. But if they did not revoke the hospice election, the hospice agency will be the one that will pay for hospitalizations or any type of care.
Okay. So
it's an all-inclusive care, yes.
Oh,
Go
okay.
ahead.
Because you talked about like when you're in a hospice, a patient is in a hospice care and going to the hospital. I wonder, like, if a patient is in hospice service and had a different emergency or different condition that warrants immediate or urgent attention, different from why the patient is hospice service, would would that um would the hospital still bill the hospice service? Like, for
No,
example, the
yeah,
patient fell.
yeah. Let me correct what I said. I'll just have an addendum or something. That if a patient goes to the hospital for other diagnoses or reasons beside the terminal illness, for
Oh, okay.
example, then the hospital can directly bill the insurance company. So
Okay.
one classic example of that, for example, a cancer patient, the terminal illness is, let's say, cancer of the pancreas, for example. The patient falls.
Right.
The patient falls, breaks the hip. Of course, obviously the patient needs a hip replacement or a hip internal fixation.
Right.
They can go to the hospital and seek help for that without affecting the hospice. Yeah.
Yeah. I
Okay.
thought the patient would be worried, like, oh, I'm in hospice care. They won't give me medical attention anymore because they're thinking that I'm gonna die in 6 months or something. Okay, so that's
I mean,
still
no,
part of
no.
dignity and comfort,
Correct.
right? Right.
True.
What do you call this? I was about to ask something, but that was interesting. In terms of like probably more uh physical therapy goals, no. You mentioned that for hospice care, hospice service, it's comfort care, right? So in formulating a physical therapy goal, what goals can physical therapists write there, not without phrasing it as anything curative, like patient will not be, our usual goals would be patient will be able to walk
Mhm.
100 feet or something like that. But in terms of hospice care, what are the achievable goals that we can do for them? How do we phrase that?
Actually, when it comes to hospice care, I would recommend that the goal should be more educational and training
Mm,
goals.
okay.
So, for example, teaching the patient and the family how to do the exercises or how to properly manage their equipment or how to manage pain. Like, for example, you will teach them that if they're in a lot of pain, they can use the TENS unit for 15 15, 30 minutes, and, things like that. So more on like education and training goals. But when it comes to like functional, I don't see the point.
Okay. So more on education when a physical
Yeah.
therapist goes to a patient in hospice service. Gotcha. So you
Mhm.
touched on this earlier that the hospice care or hospice services in the top of the like totem pole of services, like because I remember I had a patient with chronic kidney disease I was seeing for home health, and on my way to that patient, the office called me and said, "Are you about to go to? Did you see this patient today?" I told them, "No, I'm on my way there right now." And they said, "Oh, you don't have to go there anymore. Hospice is already there." I was like, "Okay," and I just let it go. And then later on, I found out that home health and hospice cannot exist at the same time. So when hospice is there, home health is gone already.
I mean, practically, yes,
Mm-hmm.
on your example, but technically they can coexist. I
Oh.
mean, not coexist, but I mean, they can have both uh, hospice and home health at the same time. But remember, when there's a terminal diagnosis, the hospice care should be focused on the terminal diagnosis. But
Mhm.
what if the home health is, for example, our example on the one that had a hip
Oh
replacement
yeah. Uh-huh.
goes home, needs
Uh-huh.
physical therapy, for example. So the home health diagnosis will be different from the hospice diagnosis. And home health patients can be seen in home health. But the
Uh-huh.
problem that we have, that's why I said it's uh, technically you can have both home
Uh-huh.
health and hospice at the same time with two different diagnoses. But practically, it's very difficult because it's in a ways a cost for an audit. I
Uh-huh.
would, if you ask me,
Mm.
because if they see it, this patient is on hospice, why is this patient being seen for home health? I mean,
Right.
some agencies just refuse to have that type of burden when it comes
Mm-hmm.
to so they'd rather just have one service.
Mm-hmm.
I
Right.
mean, believe it or not, you can have outpatient therapy while you're having hospice.
Oh, really?
Yeah,
Okay.
but the problem there is like what I said, a lot of the outpatient facilities I know, they don't do it because when it comes to billing and all that and trying to
Mm-hmm.
justify physical therapy in an outpatient while receiving hospice,
Uh-huh.
it's kind of difficult. So what one some hospice agencies that I know, instead of having this patient go to outpatient and will what's this complicate the billing process, they
Mm-hmm.
just pay for the physical therapy of the patient in an outpatient. I mean,
Ah, gotcha. Okay.
instead. So it's like a letter of agreement or something, but ultimately the hospice agency is taking that hit
Mm-hmm.
on those
Okay.
types of cases.
So the outpatient physical therapy can would not bill the insurance, but just wait for the hospice service to
Pay
pay
for it.
them. Oh, okay. Gotcha.
Yeah, those are the ways that hospice agencies that I know
Does it?
tackle these type of
Mm,
conflict. Yeah.
okay. Yeah. In my example, because we're either when I was in home health and the hospice care came into with my patient, it's the same diagnosis because I was seeing the patient because of that diagnosis, and hospice came over and took over that. That's why we had to exit the
Discharge the patient
discharge
immediately,
the
right?
patient. Yeah, right. Discharge from last visit, something like that.
Mhm.
So, yeah, so that's enlightening. I didn't know that can happen or that that is possible for patients. Are there any, things that we should avoid or, promote in caring for patients with or under hospice or palliative care?
I mean, one thing that I will tell the. I mean, are you talking about physical therapy and
Physical
palliative
therapy,
care?
yeah. Hmm.
Yeah. When it comes to that, don't promise patients anything, because
Hmm.
sometimes we get out of that paradigm, the philosophy of comfort care, and these patients will start to, or the family members will think otherwise and say, okay, my mom will get better and all that. So instead of keeping hospice services, they want to be discharged from hospice because, they feel like the mom or the dad will get better, especially if the PT is not properly educated on the hospice philosophy. For a PT, tips that I can, instead of the do's, the don'ts, as a PT, when you're doing your interventions, always tie everything into symptom relief and comfort provision and manage pain. Don't make promises to these patients that your mom will get better, can walk a mile after,
Right.
you're doing this and all that. And you also have to explain to them that the physical therapy is not here to help cure the patient, but to provide comfort as much as possible. So when it comes to hospice care, these are practical tips that I want to tell anyone. Number one is, while you're healthy and you're able to make decisions, always start embracing the possibility of death and start making decisions while death is far, not when it is imminent. That's one classic example I have is my mom, for example. Like I said, in 2014, my brother and another brother from Canada, we all flew to the Philippines because my mom was, in coma for a few days. And during that time, we had to make the decision: are we going to pull the plug or not? It was a very difficult decision. So I just realized that, if our mom actually wrote something, or there's like a will and testament and all that, it should have been easier. For us, it's really, that stigma with death is something that we need to remove, because like what I said, it's an eventuality of life. So start making advanced care planning while you're still alive. Right. Also, when it comes to hospice, also tell the patients that it's not the end. Sometimes patients get better even though they're terminally ill. You can revoke your hospice election anytime. So, and not because a patient is on hospice means that that's it. There are times that, the patients get better, they get out of hospice, and they can, go back to home health, right? So make those, like what I said about going back to the advanced care planning, make the difficult conversations with your family about death, about funeral, about memorial services, about hospice care. And healthcare wishes should always be written or spoken. So if you're familiar with the POLST, the pulse, those ones are very important in hospice care as well, but there has to be a document that's written. So, and also patients that undergo hospice care, there is this other stigma that once they go through hospice care, especially when there's a chaplain involved, then they cannot practice their religious preferences too. That's not true, because so supposedly spiritual care in hospice is non-denominational, so it has to work hand in hand with the clergy of the patient or the family. And also look into the support system. So one of the issues that we have normally, especially patients, if they live by themselves, there's no family member, it's really difficult to provide hospice care. For me personally, I don't want to die alone. So that's the thing. Those are the difficult conversations that you need to start having with, if you don't have family members, at least close friends.
Mm-hmm.
Okay. So
Right.
I mean, those are the things. And lastly, like I always say, there is dignity in dying,
Mm-hmm.
and that's what hospice care is all about.
Right. And just talking about that, it feels heavy already. Just trying to, say that discussion to start that discussion feels already heavy. But you're right.
Yeah.
It's something that you have to, think about already while you're still alert, awake, and can make decisions by yourself. Okay. Also, thank you, Ellie, for that very informational and um, learnings that you explained to us about hospice care and palliative care. And I'm sure our audience have learned a lot of things that we as physical therapists can do so much for patients who are under hospice services. Siguro we can end with our last bites, just like before. I have my three last bites, three last questions for you. And same as before, I didn't send you these questions, but I know spontaneous. So, my first last bite is: what is your recipe for success?
I would say it's a lot of prayer. I mean,
Mhm,
I'm a deeply religious person, so I feel that there is a purpose for everything that I do.
mhm,
So I mean, I know that I'm the master of my own fate and the captain of my ship, but I feel that my path has been laid right in front of me. It's
mhm,
just me trying to make sure that that path is tread.
mhm,
So it's a lot of I mean, a lot of preparation as well. Sometimes the problem is the opportunity comes, but we're not prepared.
mhm,
So when we encounter those opportunities, we should be prepared all the time. That's why, I always tell people that I know, the preparation can be, education, try to uh, continue learning all the time, so that when the time comes, the opportunity knocks, then just open the door. And I would say, lastly, uh, support system.
mhm.
So I mean, what's the purpose of all these success if you have no one to share it with? So that's where family, friends are, very, very important.
All right. Good
Oh,
answer.
yeah, I did not prepare.
Yeah, but
That's
that's good. Those are good answers. And continuing from what you said about continuing learning, my second last bite is: how do you continue to improve or develop yourself through the years?
I mean, at this point in time, I know what I want.
Hmm.
So I do a lot of not really like self-help books, but I mean, prepare myself mentally, because if I'm trying to pursue specific endeavors for myself personally, and in business, I have to be mentally prepared. So
Hmm.
I read a lot of um, what's this, self-help books. I love some podcasts. I mean, one of my favorite podcasts at this point in time is Say Hill Bloom, if you know him. So
Hmm.
just
How do you
look for
spell
the
his
podcast.
name?
Yeah,
Say Hill.
Sahil. It's SAHILBLOOM.
Okay, I'll try
So
to look
you
into
will
that.
fall in love with things that he say.
Hmm. Actually, that was my third question for you. Something you read, listened to, or watched that you found helpful. So, say Hill Bloom. And have you read anything that you found helpful recently?
Actually, one of the things I'm currently reading the book Influence,
Mm,
because I'm in the leadership position. I
right.
feel like to be able to be excellent, great leader, you have to be able to influence
Influence.
people. And those are the things that I'm working on right now. I mean, I have my own ways, but reading these types of books actually it expands my knowledge about leadership, and I really need that now, especially to be able to expand, you know, getting, I mean, going towards more endeavors in business and in personal life, for example.
Right.
I feel that I need those types of books.
All right. Thank you. We're gonna look into that influence. Do you remember who the author is?
I'm trying to. Oh my god, I forgot
All right, I'll look it up and
I have my
check
book
with you.
but just
Check with you
check
if that was it.
influence. I'm on
Okay.
like the 6th or 7th chapter of that book.
All right. And as a takeaway, something that we want our audience to take away in their practice after listening to this podcast, what is that one thing that you want our audience to really think about and take to their practice?
I mean, I would probably just say that if, especially for the physical therapists out there wanting to explore and all that, just take the first step. Sometimes what keeps you from achieving your goal is to actually do step number one. So do it. So do the first step, and the rest will follow.
All right. Gotcha. Do the first step. I like that. All right. Thank you very much again, Ellie, for coming into the show to explain to us, to educate us, inform us on what hospice care is. And for everyone listening, if you want to check out again, Ellie's first the guesting here about home health, it's in episode 12. Go listen to that. So again, everyone, thank you very much and catch us on our next episode. Thank you.
Thank you.